My name is Nabeel Arend. I've been a motor mechanic for the past 20 to 30 years. My experience started off with a simple toothache. I went to go and see a dentist, and I wouldn't say it's a story gone totally wrong, because it had its ups and its downs. And one of the ups is obviously the fact that I met Ridwan in the process. However, the start up to it was absolutely, I got painted this picture that firstly, my teeth were totally irreparable. It would be a total waste of money to repair what I had, which I understood, given the circumstances, because I put my total trust I put in the profession at hand. In this case, it was the dentist. The picture was painted to me that once they remove my teeth, all of my teeth, when I wake up, I'm going to have a preset of teeth already in my mouth. That unfortunately didn't happen. It so happened that about a week after I recovered, a week after, I felt a serrated edge on the gum where it was stitched up. And I went back, and then he discovered that in the process of removing the original teeth, the bone got chipped. So you had these sharp edges that were starting to protrude after the swelling, after the gum went down. So they cut it open, and then they smooth off, they grind off the bone, the sharp edges, they grind it off, and they stitch it closed. That was done under local anesthetic in the chair. So that wasn't a very nice feeling. So it's a conundrum of bad experiences, and I don't mean to dramatize it, but it really broke me down. At the same breath, they installed 2 inserts on the inserts for the attachments for the teeth. And I actually discovered about 5-6 years later, I discovered that attachments, it has to be removed. They have to remove it and put in fresh ones, new ones. And obviously, I don't think it was fitted correctly the first time, I'll be honest with you. And then Ridwan comes along, Matrix, my savior. They assessed it, they reassessed it, and they discovered that, like I said, the attachments, they need to be removed, and they're gonna fit 4 attachments which should have been done in the first place, and then make me a new set of teeth, and then hopefully I can I'll be back in the running.
Nabeel, it was my first year out of community service. I was working as an associate in someone's practice, and Nabeel was basically promised immediate dentures. He was told that we can extract your teeth and we can give you dentures, and once those teeth are out, dentures will go in and you'll be back to normal. And I think that's probably the first lesson that I learned, that nothing prosthetically done should be a replacement for teeth. A prosthesis should be a replacement for missing teeth. Because I still remember the day when Nabeel came in to get his dentures, and he looked in the mirror, and the dentures look fine and they look good. But Nabeel looked in the mirror and he says, "This doesn't feel like me." It's because there was someone who was smiling that wasn't smiling with his own teeth. And teeth themselves, I think no one should have perfectly white teeth, but teeth themselves come with their own character and their own personality. And when Nabeel looked in the mirror and he saw denture teeth, it just was not who he was. Obviously with time he's adapted to it, but that moment always sticks in my mind, that once you've extracted someone's teeth, regardless of how much or how committed or motivated they were into accepting that plan, you've taken a part of their identity and you've changed it forever.
And I also think that what Nabeel was promised and what he got or what he saw wasn't the same.
Yeah. And I think that this is where that conversation between not just patient and clinician is so important. Patient, clinician, and technician is important. And because everyone falls in at some point, and it's critical that everybody is talking the same language of expectation and understanding and how realistic those expectations are.
And I think it's important for patients like Nabeel because you're giving him that confidence back in who he's dealing with, where the clinician and the technician is concerned. So once you give them that individual attention, automatically you're gaining that confidence again from the patient, which is lost because of his past experience.
So basically the treatment that we're going with Nabeel is going to follow the so-called neo-arch concept. Neo-arch, pro-arch, they're basically different terms for a very similar type of treatment option where it's immediacy, where patients will come in for implant rehabilitation, whether they have terminal dentition or fully edentulous, and the surgeon places the implants simultaneously, impressions are taken, and then from there on in, sends off to the laboratory, and we're able to immediate load or provisionalize these implants within 48 hours. So there's obviously the added benefits of returning the patient to function, aesthetics, phonetics immediately, as opposed to having implants placed, allowing the 3 months of integration and then loading those prostheses or placing a prosthesis on that implant.
So for Nabeel, we'll be doing an immediate.
Yes, immediate lower.
Okay.
So we'll obviously do the planning beforehand. For him, we'll place the mandibular 4 to 6 implants. Once we've come up with the correct wax up, then we'll correlate that to the CBCT scan, and then have the implants placed, immediate loading 48 hours later.
48 hours later. That was going to be my next question.
So he had 2 implants that were placed in the wrong position and had insufficient space to accommodate what he needed. And they were left there for a number of years because they couldn't restore it. It was left supposedly under the gum. It caused some bone loss around the implant on the left. So this particular implant was still buried, although losing some bone on the side wall. Okay, we're removing the other implant now. So the longer you live without any stimulation to the bone, the more bone you lose. And an implant requires bone volume, both in vertical and horizontal dimensions. So in the lower jaw, for example, we've got the main nerve canal that supplies your lower teeth and jaw with blood supply as well as sensation. So if we lose height above that nerve, then we may not have enough to place an implant. All the implants are out now. He's only had 2 implants on the bottom jaw.
So as you guys know, we're busy with a full arch case at the moment, or a neo-arch case. And in simple terms, what we're doing is a patient that currently wears a full upper and lower denture, we're converting them to a fixed denture. The pan that I have up here is a classical situation of where we would hope things to be. Basically what happens is, after wearing a denture for a long time, there's bone loss that occurs naturally. Whether it's just bone loss because the teeth are not there or an ill-fitting denture, but the net result is that there's been bone loss. In the lower jaw specifically, the consequence for future implant work is that there's a nerve canal that runs in the mandible. It's called the inferior alveolar nerve. And if we wanted to place implants to restore this patient to a fixed rehabilitation, the height available of bone above the nerve to the crest of the bone doesn't allow a standard length implant to fit in there. And at times even a short implant doesn't fit in there. So what the surgeons do for us is, yes, the surgeons are cool, they place implants at angles. And with an implant placed, with two distal implants placed at angles, allows them to engage the good bone in the anterior mandible where there's no nerve. So that nerve runs down the mandible but stops around where the premolars used to be. And there's no nerve in front. So the implants can be placed at angles. Where we become cooler than the surgeons is that we can now add attachments, or almost in simple terms, elbow joints, onto the implant that straightens up the emergence. Because obviously currently if the implant is placed at an angle, my prosthesis needs to sit flat down on a flat implant interface. And we place these butt joints to correct that angle. Similarly, in the maxilla, when there's alveolar bone loss that occurs, we have the maxillary sinuses that become quite enlarged as well. And as the same as the mandible, the amount of space below the sinus and the crest of the ridge is not enough for a standard length implant. So surgeons will place implants at angles to skip the sinus, because there's obviously no sinus in the front of the face that affects implant placement. And that's how we go with a full arch reconstruction in this type of situation. So ultimately what's happening right now is Dr. Bamsey is placing those implants, and once the implants have been placed, I'm going to get in there and choose the correct angled abutments to use here. These abutments either come as 0 degree, or they come as a 17 degree or a 30 degree. And I choose the correct angled abutments with the correct heights. And the height will basically mean how deep his implant is placed in relation to where the gum is. So the implant is placed on the bone level, the gum level is slightly higher than where the gum is slightly higher than where the bone level is. So angles and heights become important at this stage here. Place the abutments, make sure all my abutments are parallel, and then we can take the impressions from there afterwards. So let's go have a look. Implants were placed at angles like I showed you earlier, and this is just a try and pin to see that I've been able to re-angle it adequately. So I use 30-degree angle corrections on the posterior implants, because obviously those were the implants that Fahim placed anteriorly. The blue one here is a 17 degree, because the mandible or the bone resorbs in such a way that Fahim was only able to place the implant in that position, so I'll re-angle that with a 17 degree joint. It's minimal, but it'll look better at the end. And this normal gold one here is just a straight one. So this implant was placed in good bone and was able to be placed prosthetically in the correct position as well. Impression material needs to be nice and rigid as well. You don't want something that's going to be too elastic. Pretty much the impressions are taken. The bite registration has been taken as well, so the patient gets to recover. All of this work, the impressions go to the laboratory, and the guys from Inline will start manufacturing the prosthesis on the implant analogs. It's Thursday afternoon now at 5 o'clock, so we'll probably have things ready for him by tomorrow afternoon, and then we can deliver some teeth for him. It's obviously important that we get these teeth loaded. Immediate loading, in essence, is where you can load these implants within a week, but we want to get these implants loaded ideally within the first 48 hours before any swelling does actually kick in. So he will have a bit of pain this evening, but the swelling will kick in from 48 hours beyond, 48 to 72 hours. So we're going to get the prosthesis in before the swelling happens, so it makes delivery a lot more comfortable for him. But let's see how this goes. Thanks.
When biting, chewing, laughing, they're going nowhere. The teeth are going nowhere. Yes, that's the biggest problem, is the weight, because you eat so much more. From temp to final, your intake is going to be greater. You're going to be eating much more. With the current setup, you bite into anything, everything, you just enjoy yourself. Your bite is so much more confident, while your smile is also confident. The compliments, you get compliments about your teeth. It's either you're going to tell me the truth is not your teeth, or you're going to accept the compliment. I seriously don't think people know that it's not real, which is a good thing. You know, from start off is that you have a bit of a lisp, it takes about a day, and then you'll forget about the lisp and you'll start to speak properly, and that's about it. So I mean, your adaptation period is probably about a day. You know, I'm specifically referring to before. You've always got that fear that you're going to break something, or something's going to flip out of your mouth, or you're going to bite again and your teeth are still stuck into the apple. My teeth has got character, and it adds to my character.
You? I think that's
Let's go. Dentistry to me has always been a problem. Had I known back then what I know now, I'd have probably sorted it out way back then.